Okay, the topic for this video is we're going to start to talk about hormone therapy. I'm going to begin with a brief review of the endocrine system and hormones, and then the rest of the video will be discussing the adrenal hormones and their indications for adrenal hormone supplementation or corticosteroid treatment. And then I'm going to discuss Addison's disease and Cushing syndrome at the end of the video. So, like the nervous system, the endocrine system is the other major controller of homeostasis. So as we know, nerves exert instantaneous control over basically our muscle fibers and our glands. With the endocrine system, we see the secretion of hormones from endocrine glands or organs into the blood, and those hormones then can affect all the body cells. But oftentimes it's going to take a little bit longer, up to a couple days in some cases, to produce an optimal response. But then the response will persist for quite a long time. So it's slower to act, but longer acting overall. The endocrine system is in comparison to the nervous system. As we know, hormone balance is kept within a normal range, and either too much or too little of a hormone can produce pretty profound changes to physiology. So what I want to do first is just kind of run through the endocrine glands and organs on this slide, and then talk about the hormones that they secrete. So the main endocrine glands or organs are starting at the top there of the slide with the pineal gland. The pineal gland is kind of right smack in the center of the brain, and the main hormone that the pineal gland is responsible for secreting is melatonin. Then we have the hypothalamus and the pituitary, which work really closely in tandem with one another. The hypothalamus is going to directly control the pituitary gland, either by exerting or by secreting a hypothalamic hormone into a very small vascular bed called the hypothalamic pituitary portal system, or in some cases, the hypothalamus actually, the cell bodies of the neurons are in the hypothalamus, and the axons extend into the posterior pituitary. So the hypothalamus is actually a direct extension the posterior pituitary, is a direct extension of the hypothalamus. So we'll run through those hypothalamic and pituitary hormones on the next slide. The pituitary gland sits just beneath the hypothalamus. Like I said, it's actually physically connected. The back of the pituitary gland is physically connected to the hypothalamus, and that's the posterior pituitary. The front of the pituitary gland is called the anterior pituitary, and they communicate via a portal circulatory system. The anterior pituitary is going to secrete more hormones than the posterior pituitary, which again we'll go over in the next slide. Then we move down into the throat, and you see the thyroid and the parathyroid. The thyroid gland and the parathyroid glands. The thyroid gland is kind of in charge of our overall whole body metabolism, and the parathyroid glands sit on the posterior surface, even though on that picture they look like they're on the anterior surface of the thyroid. Parathyroid glands are instrumental in controlling blood calcium. The thyroid gland, in addition to controlling metabolism, also plays a role in calcium regulation as well. The thymus gland sits on top of the heart, and it's larger in childhood, and it atrophies as we become adults. The thymus gland is responsible is the location of the maturation of the T lymphocytes, which we talked about in our previous video briefly. The adrenal glands are going to be the topic of this particular video outside of the introduction to the endocrine system. The adrenal glands sit on top of the kidneys. The adrenal glands have two portions. The inner portion is called the adrenal medulla, which secretes epinephrine and norepinephrine, and those guys are called the catecholamines. The outside of the adrenal gland is called the adrenal cortex, and it secretes the hormones we're going to talk about today, which are the glucocorticoids, the mineralocorticoids, and also some degree of sex hormones. The pancreas is an endocrine and exocrine gland, which is sort of interesting. And the pancreas in the endocrine capacity is responsible for blood glucose metabolism, which we'll talk about in our next video on diabetes. And then finally on this slide we have a female, and so the gonads are our last endocrine gland, or the location of our last endocrine glands. In the case of a female, we have ovaries secreting estrogen, progesterone, and in the males we have the testes secreting testosterone primarily. So let's flip and look at, again, what we're looking here specifically at is the hypothalamus at the top. Let me find my cursor. So the hypothalamus, pardon me, would be in this region up here. The pituitary, anterior and posterior, and you can see this direct connection here where we've got the cell bodies in the hypothalamus and they terminate in the posterior pituitary. And then we have all of our anterior pituitary hormones here, our posterior pituitary hormones here, and then the targets that they affect. So I just want to kind of talk to you a little bit. There's a key up there on the right-hand side for what those abbreviations stand for. But I want to talk to you about a couple of these. So at the hypothalamic level, remember the hypothalamus is going to directly control the anterior and posterior pituitary. The hypothalamus is going to secrete hypothalamic hormones into the portal circulatory system to direct the action of the anterior pituitary. And those hormones are corticotropin releasing hormone. The next one we have on our list is thyrotropin releasing hormone. Then we have growth hormone inhibitory hormone. And we have, I'm going to skip one to growth hormone releasing hormone. Then we have our prolactin inhibitory hormone. And then we have our gonadotropin releasing hormone and our melanocyte stimulating inhibitory hormone. All of those are coming from the hypothalamus, and they're directly influencing the secretion of hormone from the anterior pituitary. Before I go into the anterior pituitary hormones, let's really quickly, because there's not as many, let's talk about the posterior pituitary. So you can see again here in this picture that the cell bodies are located in the hypothalamus and the axons extend and then they terminate in the posterior pituitary. So the hormones that are released from the posterior pituitary are antidiuretic hormone and oxytocin. Antidiuretic hormone is a hormone that we talked a little bit about when we talked about the kidneys, and the target organ for antidiuretic hormone, which you can see there, are the kidneys. And basically the job of antidiuretic hormone is to allow us to reabsorb water. So kind of the stimulus for release is anytime we have an increase in the concentration of the blood or a decrease in blood volume, then we'll see antidiuretic hormone released from the posterior pituitary. Oxytocin is the other posterior pituitary hormone. The target for oxytocin is twofold. We have the uterus and also the breasts are targets for oxytocin. With stimulation, or pardon me, what oxytocin does is it stimulates uterine contraction. And the stimulus for release is usually the stretching of the uterus during childbirth. And also as the baby's head puts pressure on the cervix, that does it as well. And for the breasts, the stimulus for release of oxytocin is infant suckling, and the response is the ejection of milk, or the letdown reflex of milk. So let's talk about the anterior pituitary, starting at the top left there with adrenocorticotropic hormone. So adrenocorticotropic hormone is released by the anterior pituitary, and what it does is it is going to stimulate the adrenal cortex to release glucocorticoids primarily, which we're going to talk about in a little while. So you can see the link there to the adrenal cortex. Thyroid stimulating hormone is another anterior pituitary hormone, which is going to cause the thyroid gland. It's going to stimulate the thyroid gland to produce more thyroid hormone. The thyroid gland, produces two types of hormones. One is T4 and the other is T3. And the more T4 is produced by the thyroid gland, but then it has to get converted to T3. And I'll talk about that in an additional video. Then we have growth hormone. Growth hormone is the target for the targets for growth hormone, I should say, are relatively abundant. The targets are bone, muscle, liver. And what growth hormone does a lot of things, but one of the things it does is it promotes growth, which is kind of obvious. But the other thing it does is it mobilizes blood lipids, and that's the effect really on the liver primarily. Then we have prolactin being released, and what prolactin does is prolactin's job is to promote lactation, which you can see happening there. Kind of similar to what oxytocin does, but oxytocin is a little bit more around the letdown reflex. We have FSH and LH. FSH and LH, FSH stands for follicle stimulating hormone, and LH stands for luteinizing hormone. Depending on if it's a male or a female that we're talking about, the FSH and LH are going to act on either the testes or the ovaries. FSH in a female is going to promote the maturing of ovarian follicles and also estrogen production. LH in a female is going to stimulate ovulation and also the production of estrogen. FSH in a male is going to stimulate the testes to increase sperm production. And LH in a male is going to stimulate the testes to produce testosterone. So the adrenal hormone, the anterior pituitary hormone, gonadotropin releasing hormone, will stimulate both. From the hypothalamus will stimulate the release of FSH and LH in both females and males. Then we have melanocyte stimulating hormone, which is going to stimulate our melanocytes, which, as we know, they lay down the pigment melanin. We'll talk a little bit more about that when we talk about Addison's disease in a little while. So I think that's a pretty good, quick and dirty overview of the hypothalamus, the anterior pituitary hormones, and their targets. So, as I said previously, the endocrine system works a little bit differently, quite a bit differently actually, from the nervous system in that it causes hormones to be released into the blood. That's really the big difference in terms of the way of communication. We consider both the nervous and the endocrine system as distance communicators, but with the endocrine system, it truly is a distance communication in the sense that these hormones, whether they're steroid hormones or protein or peptide hormones, they get secreted into the blood, and then they enter circulation, and then the hormone's carried throughout the body until it finds its target. When it finds its target tissue, the hormone then will bind a receptor on the target tissue's cell membrane or inside the cytoplasm or the nucleus, depending on the type of hormone, and then it will exert its effect at the target cell. Sometimes we call those effectors as well. So it's really truly a distance kind of a setup. Again, the only tissues that are going to be sensitive to those hormones are the tissues that have receptors for those hormones. So even though we've got all this hormone potentially running around in the blood, the tissues that are going to be affected by the hormone are the tissues that have receptors. In some cases, like thyroid hormone, we have a whole bunch of receptors on almost all body cells, whereas other tissues are going to be more selective. All right, so since this is a pharmacology class, we're really going to kind of focus more on the use of hormones as therapy. And traditionally, hormones are used either in relationship to this conversation, are really used as replacement therapy in cases where hormone levels are low or absent. But in some cases, and this is going to be especially applicable in our conversation around the adrenal gland, in some cases, we are looking for the pharmacological effects beyond replacement, meaning that they may have the hormones there, but we're going to administer supraphysiologic doses, if you will, in order to have an additional effect. And kind of the classic example of this is the anti-inflammatory or the immunosuppressant effect that we see with the administration of glucocorticoids. In cases where they may not be low on glucocorticoids, but we're trying to kind of like push the envelope, if you will, and really and really utilize some of those effects at relatively high doses. All right, so traditionally, if you know the normal effect of the hormone, then like we kind of just ran through quickly, then its uses and its side effects should be more or less intuitive. So in this unit as a whole, unit 10 of our book, we're going to talk about steroids from the adrenal cortex and uses for those. I'll talk a little bit about anti-adrenal drugs, as well. And then in previous videos, we're going to talk about diabetes, drugs that use diabetes, and we're going to talk about the drugs used for bone density. I'm going to talk some about reproductive hormones as well. And I should have added to that list, but also a conversation around thyroid hormone as well. All right, so today's topic is this topic is the adrenal gland. So what I want to do is kind of refresh our memory on the adrenal gland, what it's all about, and then we're going to talk about the use of mineralocorticoids and glucocorticoids specifically. The adrenal gland, like I said, has the outer portion is called the adrenal cortex, and that's where we're going to focus our conversation on today. The inner portion of the adrenal gland is the adrenal medulla, and again, that's where we're going to see the secretion of primarily epinephrine, but also norepinephrine into the blood. But we really talked more about the effects of those when we discussed the autonomic nervous system, specifically the sympathetic nervous system. If you remember in our lecture about the sympathetic nervous system, I said that the way I kind of think about the adrenal medulla is as an overgrown sympathetic ganglia. And so I think about it in the context of autonomic stimulation or the sympathetic stimulation. But the adrenal cortex is a totally different deal. So these adrenal glands, they sit on top of our kidneys. They basically secrete hormones that affect every body tissue. The primary secretions of the adrenal gland are the corticosteroids, which are used for replacement, but they're also used in other indications when we're kind of trying to accentuate the effects of the corticosteroids or the glucocorticoids. They treat all kinds of conditions. More frequently, they're not being used to treat adrenal conditions, but they're used to treat skin conditions, gut conditions, specifically ulcerative colitis and maybe Crohn's, a lot of allergic conditions, also a lot of inflammatory conditions like arthritis. So from our slide here, you can see that the adrenal cortex secretes 3 types of hormones. One are the mineralocorticoids. The mineralocorticoids are going to be responsible for the action of, so the main mineralocorticoid, I should say, is aldosterone, and it acts on the distal convoluted tubule, and it causes us to retain sodium and water at that location. The glucocorticoids are going to be secreted also from the adrenal cortex, and the glucocorticoids are responsible for doing a whole bunch of stuff. So cortisol is our primary glucocorticoid. Sometimes it's also called hydrocortisone. It's secreted, cortisol or hydrocortisone is secreted in the highest amount, and it's probably the most important in terms of pharmacology. The liver converts hydrocortisone into cortisone, which is the active metabolite, and cortisone is also available as a drug. We'll talk more about that in a little while. So basically what the glucocorticoids do is they are responsible for our long-term stress response and affect the metabolism of basically every single cell in the body. Their actions are super diverse, and you can kind of see them down there, but the way you want to kind of think about the corticosteroids or the glucocorticoids is, again, that they're responsible for the long-term stress response, which means that they're responsible for making sure that we make it through the stressor, whatever it is, making sure that we have enough fuel, enough of all the things that we need to make it through that stressor. So the known effects of glucocorticoids are to increase blood glucose, right? So you have the ability to have enough energy to survive through the long-term stress, increase the breakdown of proteins and amino acids, again for fuel, increase the breakdown of lipids, again for fuel, and also suppress the inflammatory and the immune response. Another thing that the glucocorticoids do is they seem to increase the sensitivity of our vascular smooth muscle to the actions of both norepinephrine and angiotensin II. So they help us to modify the tone of our smooth muscle. They also have an effect on the central nervous system, affecting our mood and maintaining the excitability of our nerves. They increase the breakdown of bony matrix, which can cause demineralization of the bone and lead to osteoporosis, which we'll talk about later on. They promote the bronchodilation by making the smooth muscle of our bronchioles more susceptible to the sympathetic, or more responsive, I should say, to the sympathetic nervous system. And so we talked a little bit about corticosteroids in the therapeutic use of asthma for that reason. And they also stabilize mast cells, which means they decrease the release of some of our inflammatory mediators, which is why they're popular for allergic disorders. So that's a whole lot of action. Glucocorticoids do a lot of stuff. Like almost all of our endocrine hormones, they are controlled via a negative feedback loop, which I'll show you a picture of on the previous slide, or the next slide, pardon me. The other thing that gets secreted from the adrenal cortex are the gonadocorticoids, which are sex hormones, essentially. And the adrenal cortex is not a huge secretor of sex hormones, so it's a pretty small amount, but in some cases, especially in postmenopausal women, this is the primary source of endogenous estrogen, and so it does become important. Sometimes if someone has a tumor of the adrenal cortex, we'll see hypersecretion of some of these gonadocorticoids, which can cause things like hirsutism, masculinization, etc. Okay, so here's an illustration of a negative feedback loop. I know you guys are pretty familiar with these, and this is more or less the way that all endocrine hormones are regulated. And that is via the levels in the target gland's hormone in the blood. So, for example, if the adrenal cortex is secreting glucocorticoids into the blood and those levels increase, then that would feed back negatively to both the hypothalamus and the anterior pituitary to decrease the further secretion of the hypothalamic releasing factor, in this case CRF, and the anterior pituitary hormone, in this case ACTH. So you can kind of plug in just about any hormone into that loop, but there's a few exceptions, one of which is oxytocin, which is a positive feedback loop, but that's like one of the very few and far between examples of positive feedback in the body. All right, so these glucocorticoids are steroid hormones. Steroid hormones are a little bit different in a couple ways, one of which they all share a cholesterol backbone, which I'll talk a little bit more about in the next slide. They also are lipophilic, which means that their receptor can be located inside of the cell, either in the cytoplasm or in the nucleus itself. So the hormones can diffuse directly through the cell membrane and find their receptor and create a hormone receptor complex, which then essentially acts like a transcription factor in the nucleus. And it changes the way that proteins are made. So that's kind of why it takes a little bit of time, but why, in the same vein, why the effects are longer lasting. All right, so let's see here. Let's talk a little bit about steroids. So, as I said, they have a cholesterol base and they're non-protein hormones. There's not very many. By far and away, the most abundant types of hormones are protein-based, but these are non-protein-based. So our secretion in this context our steroids are secreted from the adrenal cortex, so we call them the adrenocorticosteroid. And they are going to be at least partially under the control of ACTH. So there's three types of adrenocorticosteroids. One are the mineralocorticoids, and as I said earlier, the primary mineralocorticoid is aldosterone. Then we've got the glucocorticoid, which the primary one is hydrocortisone, which then gets converted to cortisol, which is the active metabolite. And that's the one that produces profound effects on metabolism that we just went through. I should say the mineral corticoid aldosterone is the one that helps us to retain salt and water from the distal tubule. And then finally, our reproductive hormones are the androgens, testosterone, DHT, estrogen, and progesterone, which we'll talk more about those in another video. So really quickly, the mineral corticoids, really important for life. They maintain our electrolytes, specifically sodium, potassium, and then indirectly blood volume, because sodium is the big regulator of water. Water will follow sodium wherever it goes. So if you were to be utilizing a mineral corticoid therapeutically, most likely you're going to be utilizing it or administering it in the case of an insufficiency situation. So the primary adrenal, there's different types of adrenal insufficiency, which I'm going to get to in a minute, but the one that we're going to spend a little more time talking about is Addison's disease, which is an autoimmune disease leading to atrophy of the adrenal cortex. So we can't use aldosterone directly, there's not enough of it, but we can use other drugs that have a more pronounced mineral corticoid effect. So you can see desoxycorticosterone, was used first, but we now use a derivative of hydrocortisone called fludrocortisone, which affects the adrenal cortex, but it has a more pronounced effect on specifically the mineral corticoid. So specifically the ability to maintain these electrolytes and blood volume. So the glucocorticoids, they do a bunch of stuff. So I kind of ran you through this on the other slide, and I think for the most part all of this is repeat of that information, but I just kind of want to emphasize this, because these are the ones that really are used most clinically, and not necessarily for replacement, more for some of these additional effects of glucocorticoids. So again, they stimulate the formation of glucose from wherever we can get it. So protein, they stimulate the release of insulin. They have an anti-insulin effect. They can, which means they help us to utilize that insulin. They have they increase, I think I said this already, they increase the breakdown of protein, they increase the utilization of fatty acids for energy. So they really help us to cope with stress, and this is the long-term stress. The immediate stress is really the short-term stress response, which is driven primarily by the adrenal medulla. This allows us to have more fuel to last over the long haul, making more building blocks available to make more glucose available ultimately. And they also do they potentiate the action of the catecholamines that are released from the adrenal medulla. And then probably the most common use of corticosteroids or glucocorticoids therapeutically is to utilize this anti-inflammatory effect. So what they do is they help to prevent the leaking of fluid out of the capillaries. They help to prevent the formation and the infiltration of leukocytes in the immune response. And they help to prevent the formation of fibrous tissue during the healing process of the immune response. So therapeutically, why would we want to give somebody glucocorticoids? One is if they're not making them, and that's going to be Addison's disease, which is essentially an adrenal failure. And I'm going to talk more about that in a minute. Sometimes if we're trying to figure out what's going on with the adrenal glands, they can use glucocorticoids diagnostically to suppress adrenal corticotropic hormone. So if we're trying to see if there's like a problem with the pituitary gland, for example, if you give somebody a bunch of glucocorticoids, that should inhibit the further release of both CRH and ACTH. And so that's the diagnostic use here. And then any kind of inflammatory response that's not an infection, you don't want to give them if they have an infection, because that decreases, in addition to the suppressing the inflammatory response, it also suppresses the immune response. So these are cases where you have inflammation in the absence of infection. So rheumatoid arthritis, rheumatic fever, inflammation, and if somebody has had some kind of tissue and or organ transplant, and you don't want their immune system to reject that tissue and or organ. We also mentioned the bronchodilatory effect. making the smooth muscle of the airways more receptive to bronchodilation. And in some cases of cancer, we use them to suppress the immune response. So you can see leukemias, suppressions of the lymphocytes. In terms of toxic effects, this lady on the slide here is actually a Cushing syndrome lady, which we're going to talk more about, but you can precipitate a Cushing's-like syndrome if you after the long-term administration of glucocorticoids. So the things you're seeing on this slide are characteristics of Cushing's, but also of long-term chronic glucocorticoid therapy. So one of the things that we know about giving somebody glucocorticoids is that it's going to suppress essentially the further production, or it's going to shut down that production, right? That's negative feedback. So we can see atrophy of the adrenal gland, which can be challenging if you're trying when you're trying to take somebody off of these medications. And I'm going to show you a slide of that in a second. We would expect if someone's on glucocorticoid that we would have a suppression of the immune response and the inflammatory response. So you'd see delayed healing. So you see, slow to heal, decreases in new connective tissue, forming, reduction in resistance to infection. Peptic ulcers, a direct irritation. The mucosa of the GI tract is directly irritated by the glucocorticoids. And so you can see ulceration and potential for perforation. Amenorrhea, when we mess around with the adrenal hormones, we also tend to throw a bunch of other endocrine glands out of whack. The two that are most notable, even though the connection is not clear in terms of why this happens, but the ovaries in a female and also the thyroid gland tend to get pushed out of whack when the adrenal hormone levels are high, in this case because of administration. And then, of course, they're going to mimic Cushing syndrome, which you see there. So we'll talk more about that in a bit. So these toxic effects of glucocorticoids, osteoporosis we talked about before. Cataracts are common with glucocorticoid use chronically. Stunting of growth in children, I believe we talked about this when we talked about asthma. And they do get a lot of CNS stimulation, and so the symptoms can be kind of all over the map with this, in terms of they can be kind of restless or anxious, they can have difficulty sleeping, this can precipitate manic depressive episodes as well. A whole bunch of drugs interact with glucocorticoids, so they have to be considered. The anti-diabetic drugs, which unfortunately oftentimes our patients are going to have quite a bit of elevation in their blood glucose because of the glucocorticoids, and the anti-diabetic drugs interact poorly with these medications. Oral anticoagulants, a whole bunch of vaccines, anything that can cause potassium loss will be potentiated with glucocorticoid administration, and that can be quite dangerous because potassium is very tightly regulated, and either high or low levels adversely affect the heart. Glucocorticoids also tend to make aspirin less effective. And then we have a lot of caution with withdrawal because of the adrenal atrophy, which I'm going to talk about in a minute. And the other thing, once somebody's been on glucocorticoids, then their immune system and their inflammatory response has been suppressed. If they're placed under and their adrenal glands have atrophied to some degree, any kind of stress, and stress is a fascinating thing because it doesn't matter what the stressor is, the adrenal gland responds in the same way. So any kind of stress, including surgical stress, can cause problems. So one of the big things to keep in mind when administering corticosteroids as therapy is that if they've been on them for a long time, chronic use, that the adrenal cortex is going to atrophy. And that's just due to the suppression of the hypothalamic CRH and the the anterior pituitary ACTH. So the adrenal cortex isn't being stimulated to produce adrenal hormones because of the feedback, and therefore the adrenal cortex atrophies. And when needed, it's not. So if suddenly you discontinue the glucocorticoid therapy, their adrenal cortex has atrophied, and so they're not going to be able to respond in kind by secreting glucocorticoids when necessary. So really what has to happen is they have to be tapered off of these drugs very slowly and depending on the duration that they've been treated, it can take quite a long time to taper them off. If they withdraw suddenly, you can see down here at the bottom, sudden withdrawal of corticosteroids leads to an acute adrenal insufficiency. And the symptoms are going to be hypotension, lethargy, renal failure, nausea and vomiting, and the final symptom is asthenia. So this again is due to sudden discontinuation, and it's going to be specifically pronounced if they've been on the drugs for a long time. And so there's a lot of question in terms of like how long is a long time, and it kind of depends on the patient. In some cases, just like, if it's just a few weeks, it's generally not a big deal, even though in the dosing strategy, what they generally will do if they're someone's prescribing corticosteroids, they tend to step them up and then sort of plateau and then step them down, even if it's in the case of like a skin situation like eczema, or like classically like poison oak or poison ivy, for example. It's self-limiting, it goes away, but in that period of time where they're really inflamed, the corticosteroids can really help. In some cases, it's the only thing that can work. And so they step up, they plateau, and they step down. And if they follow the instructions, then generally the withdrawal is okay. But if they've been on them for a long time, like for example, they have COPD, or they have asthma and they're using a corticosteroid inhaler for years and years, then if they discontinue suddenly, that's when we're going to see some of these side effects. I don't think I mentioned I don't know that I defined asthenia, but asthenia is essentially just lack of strength or loss of strength. And it can be kind of to the extreme of complete debility. All right, so I want to finish with talking about Addison's disease and Cushing syndrome. Addison's disease would be a case of adrenal insufficiency, and it is rare. It's an autoimmune disease which causes destruction of both adrenal glands. There's other things that can cause adrenal insufficiency, and these would be secondary to the adrenal gland itself. So hemorrhage is one. An infection or a metastasis in the adrenal gland, so a cancer that comes from someplace else, can cause adrenal insufficiency. Secondary adrenal insufficiency is much more common than Addison's disease, but in either case, the symptoms are going to be the same. And so you can see our lady there. She's our classic Addison's lady. So the big symptoms are hypoglycemia, or low blood sugar, fatigue, like asthenia, like we were just talking about, muscle weakness, hypotension, because they don't have the mineral corticoid aldosterone to increase the reabsorption of sodium and water, increased skin pigmentation, which is sort of an interesting one. I'm going to go to the next slide, and then I'll come back. So what happens with the skin pigmentation? And this is sort of a strange thing. So remember, one of our adrenal corticotropic hormones was melanocyte stimulating hormone. So when the levels of with Addison's disease, as you can see here, this is where the adrenal cortex should be. It autoimmune destruction, so the whole thing kind of shrivels. So it's adrenal cortical atrophy. So in this case, they would have low levels of aldosterone in their blood. They'd have low levels of glucocorticoids in their blood. They'd have low levels of sex hormones, although there's other secretors of sex hormones, so that's not quite as noticeable. But when those levels are low and what that would do is that would cause no inhibition of ACTH. So ACTH should be being secreted like crazy from the pituitary gland. And one of the things ACTH does is it stimulates melanocytes, and it causes this increase in pigmentation of the skin. And when there's no adrenal cortex to stimulate, we sort of get this overstimulation of the melanocytes, which is what drives this pigmentation picture that you see on our slide here. So this lady has hyperpigmentation, and their skin takes on like a early days of tanning cream kind of an appearance, sort of this orangish bronzy color. Their hair does the same. Anywhere you have melanin, nipple creases, that's the same. Oftentimes they'll get pigment lines concentrated in the creases in their hands, and also in any scar tissue they might have. And they can develop vitiligo, and the vitiligo is just basically burning out of the melanocytes where they just don't secrete any more melanin, so that they lose pigmentation in those areas. So the skin pigmentation is kind of a classic symptom of Addison's disease. They also have a lot of GI disturbances, and it centers around loss of weight, nausea, vomiting, and quite a bit of diarrhea. So in this case, what you're going to have to do with either adrenal insufficiency or in the rare cases of Addison's, you're going to have to replace those hormones, the glucocorticoids and the mineral corticoids. And I put some possibilities. So on the list there, they're all a little bit different, but they have a similar effect. So I just included them so you have them. Betamethasone probably, and hydrocortisone and prednisone are ones that you might be familiar with, but they're all drugs that stimulate the adrenal, that act like glucocorticoids. All right, so we looked at that. So as I said, there's other reasons to administer glucocorticoids, and these are the common reasons, and so you can kind of look over those. So you can see we've already sort of talked about the pharmacologic action and why you might want to do this, and then here's the indications. And you can see on this list anything from inflammatory conditions, asthma, COPD to open the airway, lots of skin stuff, right? So eczemas, psoriasis to some extent, although corticosteroids don't seem to be as useful for them, but any kind of contact dermatitis. I mentioned poison oak, poison ivy, which is a type of contact dermatitis, and eczema could be on our list. Allergic issues like anaphylaxis, potentially, although epinephrine would probably be the better choice. Allergic rhinitis, inflammatory bowel disease like Crohn's and ulcerative colitis. Corticosteroids are used a lot in autoimmune conditions to suppress the general inflammatory response, and the classic example here is lupus, systemic lupus erythematosus. And we mentioned the to mitigate or to decrease the likelihood of transplant rejection or graft rejection. And also when we talked about the eye, we talked about conjunctivitis, which is just an inflamed conjunctiva, not an infected conjunctiva. That's the big difference. So the final thing I want to mention to you is Cushing syndrome, which can be created and is probably the most common presentation of all these symptoms, is somebody that's taking corticosteroids, glucocorticoids, for one of the conditions we just talked about over the long term. But the Cushing syndrome is a condition that can exist on its own as well. So Cushing syndrome is just essentially very high levels of corticosteroids. It can also be due to pituitary or adrenal tumors. So you got to kind of dig to get to the base of the bottom of the Cushing's person. It makes sense when they're on drugs, but when they're not, then it takes a little more digging. So the signs and symptoms we've already talked about previously, but you can see them all on the slide, and it's represented by our lady here on the picture. So adrenal atrophy we just talked about, you would expect that. Osteoporosis, we mentioned hypertension, increased risk of infection, delayed wound healing. Acne is common, probably because of the excess testosterone and sex hormones. Peptic ulcers, we mentioned. Obesity is common. They got a lot of glucose, right? They're mobilizing glucose like crazy, and glucose, if you don't need it immediately, gets stored in fat. Another interesting thing about Cushing syndrome is they get a very interesting redistribution of fat, and where it's notable is they get this fat pad here. They call that a buffalo hump, and they also get a very round face called moon facies. They have acne. You can see hirsutism is common, which is in this case in this female. You have sort of a male pattern hair growth on the face. They bruise easily. They don't heal quickly. They also get these really interesting stretch marks, which are characteristic. I'll show you a picture of an actual person in a minute. This is a lot of obesity. This is what we refer to as a pendulous abdomen. It hangs way down, right? And this is all due to the fat redistribution. They take on that visceral adiposity, which is super dangerous and really increases their risk for cardiovascular disease. This is a big risk for all kinds of metabolic issues. Mood changes, personality changes are common. Again, the treatment of Cushing syndrome is tricky because if they don't have a tumor and they aren't taking medications that precipitate this, then we got to kind of figure out why this is happening. But the kind of the classic treatment protocol is to antagonize the adrenal hormones, at least for a period of time. And there's a couple ways that you can do this. You're not responsible for knowing these drugs, but I'll mention them quickly. One is ketoconazole, which is an antifungal drug, which blocks the synthesis of glucocorticoids. A newer drug is this drug called pasireotide. I'm not sure I'm saying that right. But this one was approved in, I think, 2012, and it's really related to somatostatin, which is a growth hormone inhibitor, which essentially decreases adrenocorticotropic hormone, so it decreases the stimulation if it's being driven by adrenocorticotropic hormone. So that would be a question to ask. And you can test levels of adrenocorticotropic hormone and see what's happening there. Another drug called midotane is an anti-neoplastic drug, so it's a cancer drug, but it's specific for the cells of the adrenal cortex. So again, this is going to be specific to adrenal tumor that's inoperable. Adrenal cancer is not a good cancer to get. It's pretty much universally fatal, and very difficult to treat. So those are our adrenal conditions, and I will say again, I think I've already said it, but you kind of want to be sort of familiar with this presentation, this lady, because of so many people on corticosteroids. They're used a lot outside of Cushing's disease and Addison's disease, or they're not used for Cushing's disease, but they're used quite a bit for, the inflammatory and the immune suppression. And therefore, we are creating this kind of a presentation in a lot of people. This is a Cushing's patient. This was pre-Cushing's and this was post-Cushing's. And this can happen very quickly. They gain a lot of fat. The fat redistributes really quickly. This is the moon face. And you can't really tell, but if you look back here, you can sort of see the buffalo hump. She'd have a pendulous abdomen. I'd bet money on that. Here's what the pendulous abdomen looks like. And again, these stretch marks that are real common. It's these sort of longitudinal kinds of stretch marks. You'll see them around the abdomen. You'll see them in females around their breasts and males as well, as a matter of fact. So that is our adrenal conversation in a nutshell. We'll come back after this to talk about diabetes. See you then.